day, everyone. Thank you for joining me. In my seminar today, I'll be speaking about the possibility of plasmapheresis as a therapeutic approach for Alzheimer's disease. The learning objectives of my talk are listed here. First, I'll give some general background about Alzheimer's disease, the amyloid cascade hypothesis, and the current treatments that are available now and are in development for Alzheimer's disease. And then I'll review some of our own studies on hemodialysis and AD biomarkers. And lastly, I'll give an extensive review of the recent results from the AMBAR clinical trial. So this slide really shows the gravity and the challenge of Alzheimer's disease. Alzheimer's is the 6th commonest cause of death in the United States. It affects huge numbers of individuals, globally over 50 million. By some estimates, it is the single most expensive condition in healthcare currently, with the estimated costs in the United States alone being in excess of $300 billion this year. And these costs are set to rise dramatically. If we look at how we're doing against many major killers, over the last 18 years, we've done quite well against conditions like heart disease, stroke, certainly HIV, but the growth of Alzheimer's disease cases has been phenomenal. And in fact, AD is the only cause of death among the top 10 that we really have no effective means to prevent, cure, or even slow down disease progression. So there's a tremendous need for better therapeutic approaches. The pathology of Alzheimer's disease includes amyloid plaques, which are shown here. They're the accumulation of amyloid beta in the brain cortex, shown here with immunohistochemistry to amyloid beta. Also important are neurofibrillary tangles. These are composed of abnormally phosphorylated tau. They're intraneuronal inclusions seen here immunohistochemically with antibodies to abnormally phosphorylated tau. Also, an important pathology is the accumulation of amyloid beta in cerebral blood vessels, as you're seeing here. This leads to damage of the cerebral blood vessels, and certainly there is blood-brain barrier dysfunction in Alzheimer's disease. This microscopic pathology leads to gross changes in the brain, and here you're seeing a coronal slice through the brain. In the earlier stages of Alzheimer's disease, there's very clear shrinkage of the hippocampus, the part of the memory that deals with, the part of the brain that deals with short-term memory. And you see enlargement of the temporal horn of the lateral ventricles. As the disease progresses, there's much more generalized atrophy, and there's very striking shrinkage of the hippocampus with clear enlargement of the lateral ventricles and generalized atrophy. The proteins that are linked to this pathology are the normal soluble amyloid beta and the tau protein. These two proteins undergo a conformational change where they take up a beta sheet secondary structure, and this makes both proteins stick together. They form soluble oligomers, and ultimately they can precipitate amyloid beta in the form of plaques and the conchophilic amyloid angiopathy, and the abnormally phosphorylated tau in the form of paired helical filaments. These soluble aggregates of A beta and tau are thought to be the most toxic species, and a lot of therapeutic approaches in development now for AD are targeting specifically these toxic oligomers. if one looks at what drives Alzheimer's disease pathology, certainly in the rare early onset familial forms of AD, there can be missense mutations in a number of genes listed here that can increase the production of amyloid beta. But in the much more common late onset sporadic forms of Alzheimer's disease, although there are significant genetic factors such as the inheritance of apolipoprotein E4, there are many environmental and medical risk factors that play an important role. The single most important genetic risk factor for late onset is the inheritance of the apolipoprotein E4 genotype. So this is the distribution of apolipoprotein E3 isotypes in the general population versus in the sporadic AD population. And you see the overrepresentation of ApoE4 in the AD population. Having one copy of E4 increases the risk 2- or 3-fold for Alzheimer's disease, whereas in homozygote individuals, it goes up 10-fold. It is becoming increasingly recognized that the pathology of Alzheimer's disease builds up gradually over a 2-decade period. So as you can see in this slide, amyloid beta pathology develops some 25 years before the patient becomes symptomatic with mild cognitive impairment and ultimately dementia. The tau-related pathology follows the development of the A-beta deposits, and we now have a number of biomarker means to diagnose patients in this preclinical period. Foremost among these are specialized PET studies where ligands are used that bind the amyloid beta protein or the neurofibrillary tangles of the abnormally phosphorylated tau pathology. So it used to be that Alzheimer's disease required an autopsy or a brain biopsy to be able to be sure of the diagnosis. But with these new PET techniques, we can in vivo diagnose Alzheimer's disease and have an idea of the amount of pathology. This pathology is thought to be driven by the amyloid cascade hypothesis, which is depicted here. So the normal amyloid beta protein undergoes this aggregation process into oligomers and subsequently fibrils, which are the amyloid plaques in the brain and the congophilic amyloid angiopathy. This drives the neurofibrillary tangle pathology, the neuronal loss, and thus the dementia. The apolipoprotein E4 allele promotes this A-beta aggregation process and is also associated with worse clearance of amyloid beta from the brain. This slide depicts the amyloid cascade on the left and therapeutic approaches for this process currently. At the moment, we only have a few symptomatic drugs, but there are a number of novel therapies which are in development. And among these is increased clearance of A-beta by plasmapheresis. Perhaps the most advanced of these therapeutic approaches currently are various immunotherapies. And these immunotherapies can be either active immunization or passive immunization with the injection of antibodies, which can be directed to amyloid beta or directed to tau. And in a research direction in my own lab, we're developing active and passive immunization that can target both of these pathologies concurrently. At the moment, there's an antibody to aggregated forms of amyloid beta, aducanumab, which is under consideration by the FDA for actual approval. So this is a therapeutic approach that is certainly showing some promise. If one looks at the mechanism of action of these immunotherapies for Alzheimer's disease, there's a long list of potential approaches that immunotherapy works by. But among these is the peripheral sink pathway, where the binding of these pathogen associated proteins in the systemic circulation by antibodies draws out these proteins from the brain, hence the peripheral sink pathway. And this is also illustrated in this slide here, where the normal soluble amyloid beta is being produced by neurons. In AD, it can become deposited on amyloid plaques or exit the brain in the systemic circulation. Some immunotherapeutic approaches can lead to antibodies directly binding to amyloid plaques, opsonizing the amyloid deposits and leading to cell-mediated clearance. But in addition, some antibodies can bind A-beta in the systemic circulation, drawing out the A-beta from the brain and thus reducing the amyloid plaque burden, hence the peripheral sink. So already the immunotherapeutic approaches are using systemic clearance as a therapeutic approach. And an important consideration and why the peripheral sink works is the fact that A-beta crosses the blood-brain barrier quite readily. And in this early study with the Zlikovic group, we showed that a radio-labeled A-beta injected systemically very rapidly enters the brain. And in this study, we used aged rhesus monkeys, and these monkeys already have amyloid plaques like in Alzheimer's disease, and the injected radio-labeled A-beta contributed to these existing plaques. So the systemic A-beta not only crosses the blood-brain barrier, but it can contribute to the growth of amyloid plaques. In addition, in our early studies, we showed that an important means of clearance of amyloid beta systemically is via the urine. A-beta is a normal constituent of normal urine, as we're showing here by mass spectroscopy. In a more recent study, it was clearly shown that chronic renal disease is associated with increased levels of systemic amyloid beta, and the increase in levels is correlating with glomerular filtration rate. And these levels of plasma A-beta are reduced in kidney transplant recipients with a slight increase in kidney donors. There have been a limited number of studies which are listed here clearly showing that hemodialysis can produce marked reductions of plasma A-beta 1 through 40 and A-beta 1 through 42 as listed here. In our own look at this, in a collaboration study with the Renal Research Institute, we looked at patients undergoing hemodialysis who also had a ventriculoperitoneal shunt. And in these patients, the VP shunt was put in for other indications, normal pressure hydrocephalus. So certainly there's a very limited pool of patients like this where we can, in real time, look at Alzheimer's disease biomarkers systemically and within the cerebrospinal fluid. We measured AD markers using a state-of-the-art single molecule analysis Simoa technology, which is summarized in this slide. This has a very high sensitivity to femtograms per ml. And we showed in these patients that the plasma A-beta 1 to 40 shows clear reductions of around 40%. During hemodialysis. And there were also clear reductions of A-beta 1 to 42, as shown here. As expected, there were no significant changes in plasma tau during hemodialysis, since the tau protein is a much larger protein, some 70 kilodaltons versus A beta being 4.3 kilodaltons. Interestingly, when we looked at biomarkers of neuronal injury and neuroinflammation during hemodialysis, there were clear increases. So neurofilament light protein levels went up, and GFAP, a marker of neuroinflammation, also went up. Both of these plasma biomarkers are used as a measure of traumatic brain injury. So in fact, this data suggests that patients undergoing hemodialysis are experiencing a form of mild traumatic brain injury due to the fluid shifts. We have preliminary, much more limited data looking at ventricular CSF levels in two of these patients. And as you can see here, during the first hemodialysis in this patient, initially there were increases of A beta 42 with the recruitment of the most readily available CNS pool of A beta, but with the second hemodialysis session, there were marked reductions as the available pool of A beta was being reduced. And this pattern was also seen in the second patient. These changes were mirrored with A beta 1 to 40 as well, with marked reductions in both of these patients on the second hemodialysis session. This data is consistent with the limited studies looking at autopsy of Alzheimer's disease pathology in patients undergoing hemodialysis versus age-matched non-hemodialysis controls, suggesting that hemodialysis might be associated with less Alzheimer's disease pathology. So with this backdrop of clear evidence that A beta can be cleared systemically with procedures like hemodialysis or plasma exchange, the AMBAR trial was initiated. In this clinical trial, Alzheimer's management by albumin replacement, AMBAR, there was both plasma removal and albumin replacement. The setup of this clinical trial is shown here. There was an initial 6-week more intense period of therapeutic plasma exchange done weekly, followed by 12 months of maintenance low volume plasma exchange. And these were the 4 groups of patients getting high levels of IVIG and albumin, low levels, and also a group with no IVIG, and then a sham control. The procedures that the patients underwent and the numbers, as well as the percentage that had central versus peripheral access, is summarized here. When looking at the complications in this clinical trial, it's good to first look at the past literature of what sort of complications are seen with plasma exchange. And this is summarized here. And the percentages of patients that have these sorts of complications. The adverse events in the AMBAR clinical trial are summarized here. And as you can see, the adverse events are in the same ballpark of what was previously reported for complications of plasmapheresis. The most frequent adverse events are again listed here, and fairly low numbers, what one would expect to find. This is plotted here in this Manhattan chart, and you can see that the majority of adverse events fall into the beginning part of the therapy, where there was a more intense therapeutic plasma exchange, as one would expect. So these safety considerations suggest that certainly this is a feasible approach in this patient population. The eligibility criteria in this clinical trial are summarized here. So these patients met criteria for probable AD, and they had either mild AD as defined by the mini-mental state score, or moderate AD where their patients had a lower mini-mental rating. The primary outcome measures are listed here. These are activity of daily living scale and a cognitive scale, very commonly used in clinical trials. There were also global endpoints, such as this clinical global impression of change scale, and then secondary endpoints such as the mini-mental state, neuropsychiatric scales and depression scales, as well as biomarkers in the CSF. The primary efficacy analysis is depicted here, summarized in this slide. And the patient numbers and the numbers in each of the individual arms of the clinical trial are summarized in this slide. When looking at the baseline characteristics of all the patients, you can see the mini-mental scale was around 21 or 22, with a good distribution of these other measures. In the mild cohort, the average mini-mental state was around 23, whereas in the moderate Alzheimer's disease patients, it was around 19. Looking at this activity of daily living scale in all the patients, you can see the decline in the placebo versus the treated patients here. This was statistically significant with an effect size of around 52%. And this is divided in the various groups here. Looking at this cognitive scale, there was a trend for significance at 0.06 and a difference of around 66% in the treated versus the placebo group. And here is the data for each of the arms of the clinical trial. When divided into the mild patients, you can see that over the period of the clinical trial, the placebo group did not decline very much. So it really was not possible to show a treatment effect in this population based on the mini-mental. However, in the moderate group, there was a clear decline in the placebo and a statistically significant difference on the mini-mental in this population group. And this is divided into the 4 arms of the clinical trial here. Looking at the cognitive scale here in the mild group, again, there was really very little change in the placebo group, whereas in the moderate patient group, there was a clear decline, and there was a clear trend for improvement in the treated group near a significant p-value. For the CDR sum of box scale, looking at all the patients, there was a clear benefit with treatment compared to placebo. And here the data is divided into each arm of the clinical trial. In the mild group, again, a very clear, significant difference. The data divided here into each arm of the clinical trial. And this was very clear, showing benefit in the moderate group as depicted in this slide here, showing the data divided into each of the 4 groups on the right. In this global scale, you can see very high p-value, very clear difference in the treated patients versus the placebo control, with each of the groups showing high p-values here, the data in each of the 4 arms of the clinical trial. Dividing this data into the mild group, you can see clear differences, again, statistically significant, and divided into each arm of the clinical trial, and in the moderate group as well. High p-values divided into each arm of the clinical trial. In terms of the biomarkers, there were clear trends for benefit. So as Alzheimer's disease progresses, the A-beta 1 to 42 CSF levels tend to go down as the A-beta and the CSF gets deposited onto the plaques. Whereas we see that in the treated groups, all patients, and in the mild group here, there was a stabilization where there was not much change in the A-beta 1 to 42 in the CSF, whereas there was a decline in the placebo group, and this reached significance in the moderate patients. Also, with the total tau and the p-tau, there was an indication of benefit. As Alzheimer's disease progresses, the total tau and the p-tau levels in the CSF tend to go up. And you can see that this was mitigated with the treatment reaching statistical significance in the therapeutic plasma exchange period here, with trends in the other periods. So you can see in the primary endpoints, there was benefit on activities of daily living scale, with a trend on the cognitive scale. In the mild group, there was no difference against placebo, since the placebo group did not deteriorate very much, but there were clear benefits in the moderate AD group. And this summarizes the other beneficial global endpoints, with clear differences on the CDR sum of boxes, this global scale as well. So there were also indications of benefit on the CSF biomarkers. And this data has been recently published and is summarized in these 2 papers here. The possible mechanisms of action in the AMBAR trial, there are several possibilities. Certainly, it is likely that the peripheral clearance of A-beta 1 to 42 and 40 played a role. In future clinical trials, perhaps amyloid PET can be done to clarify this issue. There may have been reductions in tau pathology secondary to the reductions of amyloid beta. And again, this is a question that can be addressed in future trials with direct measurements of tau PET being done. Reductions in oxidative stress are also a possible mechanism of action, since there is a known antioxidant action of albumin. This question can be addressed in future studies by looking at specific oxidative stress biomarkers, such as isoprostane in the CSF. And also one can do PET biomarkers to directly look at inflammation in the brain. Reduced inflammation also is another mechanism, and future trials can measure CSF cytokines and look at these PET inflammatory biomarkers to address if this is a part of the mechanism of action. Removal of autoimmune antibodies is also a theoretical mechanism of action. However, this is less likely, since autoimmune antibodies have not been shown to play a clear role in Alzheimer's disease. I'd like to now acknowledge my collaborators at the Renal Research Institute, foremost Peter Kotenko, who were key in the studies in the patients with ventriculoperitoneal shunts. These are folks involved in my Alzheimer's disease center in that study. And I want to end my seminar with this hopeful note that perhaps we're approaching potential novel disease-modifying therapeutic approaches for Alzheimer's disease with these various immunotherapeutic approaches, but perhaps also with these apheresis approaches. And we're perhaps coming to just see the end, the light at the end of the tunnel, but certainly there's a great deal more work that needs to be done to bring these approaches to clinical use. Thank you very much, and thank you for taking the time to listen to this seminar. Thank you.